Good morning, ladies and gentlemen. Today we are presenting Pilon fracture. The outline of this presentation will be a definition of Pilon fracture, evaluation of Pilon fracture, and subsequent management. And at the end of the presentation, we'll talk about outcomes and complications. What is a Pilon fracture? A Pilon fracture is a fracture of the distal tibia involving the tibial plafond. But there's potential overlap with more severe malleolar fracture. Pilon fracture are usually understood to be those with involvement of the central plafond. This is a typical pilon fracture. About 5% of tibial fractures are fallen in this group. Usually it is classified into low impact pilon fracture and high impact pilon fracture. And the mechanism for low impact pilon fracture usually it is a low energy rotational forces and some axial compression. Usually there's minimal soft tissue injury and there's little articular comminution, in contrast to a high impact pilon fracture, in which there's usually high force transmitted to the fracture site, there's extensive soft tissue injury, and usually there's more severe articular and metaphyseal comminution. The standard approach for this patient, usually it is through ATLS protocol because it's high energy injury. There's APCD and this should be followed. There's a high percentage of associated injuries, and usually 30% of these fractures they are open fracture. If they are closed, the soft tissue should be assessed. And there are two common classifications for open fractures and soft tissue classification, and this is just a reminder with Gustella-Anderson classification. Grade 1 skin lesion usually smaller than 1 centimeter. Grade 2 usually skin lesion larger than 1 centimeter. While grade 3 there's extensive skin damage, and usually divided into three subgroups. 3A where it needs just the orthopedic team. Grade 3B usually needs plastic cover, and grade 3C in which there's a problem with circulation and need some vascular repair. In contrast to Cherney classification of soft tissue injury in the closure fracture, again it has 4 grades. Grade from 0 to 3. Grade 0, which is there's minimal soft tissue damage, and usually resulting from indirect injury to the limb, such as torsion or some fracture pattern. To the extreme, which is a grade 3, where there's extensive skin contusion or crush injury. The usual investigation is full blood count, Hughes and ECG. There's a nice guidelines which recommend which patient needs what. While specific investigation need plain X-ray and CT scan. A part of evaluation is to classify these fractures, and in current practice there are 3 classifications. Historically, the earliest Rudy Algawa classification, then subsequent AO classification, and the most recent is Topless classification 2005. Rudy Algawa classification usually into 3 groups. Type 1, there's no comminution or displacement. Type 2, there's some comminution and very minimal displacement, while type 3, there's comminution and displacement. AO classification, the segment that form the pilon part is segment 43, and again, as with all other AO classification, A is extra-articular, B is partially articular, and C is completely articular. This further classified into 43, type C further classified into C1, C2, and C3. C1, there's no comminution of the epiphysis or metaphysis. C2, there's comminution of the metaphysis but a sparing of the epiphysis, while C3 is comminution of epiphysis plus minus the metaphysis. Both Martin 1997 and Swansky 1997 found a moderate reproducibility at the APC level, but once it goes to subgroup, it will become not accurately reproducible. Topliss classification 2005 published her series with Professor Roger Atkins about the anatomy of pilon fracture of the distal tibia. That's published in the JBJS 2005. They looked at CT scans of pilon fractures, and they classify into families and fragment. This is also this classification based on previous papers published by Bartlett and Weiner in 2003, which had a similar idea of dividing the tibial planform into fragments, the anterolateral fragments, the diapuncture fragment, the posterolateral or the Volkmann fragment, and the medial malleus fragment. But the new about Topliss classification is that it classified into families: the sagittal family, the posterior coronal family, and the anterior coronal family. And with the low energy type, usually there's one main fracture line, while in higher type you'll get more than one fracture line. Again, in what is a new in Topliss classification, there's what they call lateral disruption and functional diastasis. The lateral disruption, I see the disruption at the fracture line there, but there's no disruption at the ankle joint itself, contrary to the functional diastasis, where there's diastasis at the joint level. Management